People will slowly start to enter the Zoom room, but Dr. Valderama-Wallace, thank you so much for joining the UMSN. You are gathered here with faculty, staff, as well as students. And I want to let you know, when the description of this talk first came out via the National Conference for Race and Ethnicity, it went across the country. And on that day, it was September 20th, 2020, I received 5 separate emails from faculty and staff saying, can we bring her here? She's using such interesting frameworks to talk about DEI. And so when we reached out to you and you agreed to come, we were just thrilled. So thank you for joining us. And also Dr. Tillman Meekins has agreed to moderate the session. We will have some time for a Q&A towards the end of the session. And thank you, Dr. Tillman Meekins, for joining us. And I hope you will introduce yourself as well. I'm going to move forward and just introduce you, and then sort of let you take the stage, and look forward to hearing about what you have to say. So Dr. Claire Valderama-Wallace's journey has taken her from physiology at UCLA to public health at George Washington University to nursing at UCSF and UC Davis in classrooms, clinical settings, and harm reduction-based organizations. She is also a member of the grassroots Filipinx women's organization, GABRIELA Oakland. She is currently an assistant professor in the Department of Nursing at California State University, East Bay, where she teaches community health nursing, community engagement, and epidemiology and social inequities. She recently assumed the role of MSN Program Coordinator and is eager to promote nursing leadership focused on serving the people and fighting for health equity. She stands upon the shoulders of ancestors, scholars, students, and kasama, which I've learned is a word in Tagalog, which I'll ask you to maybe clarify what that means for everybody. It's a powerful word based on what I've read. A vision for anti-colonial, anti-imperialist, and anti-racist nursing education, research, and practice is what guides her pedagogy, service, and scholarship. Welcome.
Thank you so much, Dr. Patel, and thank you to you and to Dr. Tillman Meekins for inviting and having our initial meeting. It's really an honor to join you. So good afternoon. I welcome you wherever you are on the lands of the Anishinaabe. I know you're all joining in from different Zoom spaces. And I'm joining here from unceded Ohlone territory, also known as San Francisco Bay Area. Again, my name is Claire, she, her, hers, and really with our time together, I'd like to start off with a kind of more formal presentation. So we're on the same page about some of these frameworks and ways of viewing the work that we do and the work that we're in and our responsibilities. And then I'd love to shift to a conversation, to a dialogue. Okay, so we're going to talk about reckoning with racism and colonialism, in particular nursing education. And ideally, it's a reckoning so that we can move forward in a real genuine way that centers healing, ultimately, right? So I'll talk a little bit about the future of nursing, talk about historical context, because I don't believe we can look forward and act in a way that advances nursing where equity is at the focus and at the heart without looking back. And seeing all the living legacies of history. And then we'll take a look at the status quo of nursing education, in nursing education, and how we in nursing education actually perpetuate the status quo. And then we'll talk about mapping for change. And then I'd love for you to just take notes and doodles, and then we can have conversation after for whatever comes up. But I always want to start off with gratitude and positionality. I would not be here if it weren't for scholars whose work I have so closely studied and continue to learn from, scholars who I cited in my dissertation and continue to in my research projects. Also, I'm talking about colonialism, and while colonialism shapes virtually every aspect of our lives, whether that's the term we use or not, or the framework we name or not, the way I come to that experience is through the fact that I'm a daughter of immigrants from the Philippines. And so that living, ongoing legacy of imperialism between the US and the Philippines has absolutely shaped how I view everything and how I relate to folks. My education, Dr. Patel, that's part of my my bio, but I think what I really want to uplift through that is the immense amount of privileges that I've had. It's not because I'm smarter, it's because of a lot of the class privilege that came with my parents being from a country that was colonized and they were forced to learn how to speak English, and all the pathways that allowed for them to migrate here. So there's a lot there. So there's a lot of privileges and surprises. I never thought I'd be a researcher. I never thought I'd be a nurse educator. So all these things have come through surprises. And also silos. If you look here, you know, I majored in physiology. I loved chemistry. I hated physics. I struggled. But I also took some ethnic studies courses, and I felt like, why is my life and my mind so fractured in this university with such amounts, you know, such amazing amounts of resources? I had to take one composition course to fulfill a requirement, and it just happened to be public health. And I realized that's what I want to pursue. And then I pursued that, and then I thought, you know what? There's certain skills and ways of viewing the world that I felt were lacking in terms of how I wanted to be of service and to connect with folks. And so I pursued nursing. But when I did my doctoral degree, I found that my home was mostly in courses focused on education and sociology. And so throughout everything I do, including my learning and lived experiences in community, in the organizing world, I'll say, I'm always trying to bring them together, always trying to have them have a home in some space. And so trying to transgress those silos is a pattern. And also I'm really driven by critical social theory. And really a commitment to study, to learn through my mistakes, and ultimately action and accountability. So just to be clear that that's my positionality, and you can see loved ones and ancestors on the left. So I want to start off with this really powerful quote by amazing lesbian poet, Black author, thinker, Audre Lorde, because I'm asking us together to scrutinize nursing education. The quality of light by which we scrutinize our lives has direct bearing upon the product which we live, and upon the changes which we hope to bring about through those lives. So an assumption here that I would invite us to have is education. Ultimately, can we see that as scrutiny and change, right? So it's something for us to consider. Also, silence. The fact that we are here and that I speak these words is an attempt to break that silence and bridge some of those differences between us. For it is not difference which immobilizes us, but silence. And there are so many silences to be broken. So if you're feeling called to doodle and list out some of those silences that you live, that you experience, that you have borne witness to, that you have read about, that you have, you know, lived in multiple ways, I encourage you, and we can talk about that later. But let's think about scrutiny, and let's think about breaking silences in our time together. Okay, so we know 2020 was a year, and it feels like it hasn't quite ended. But I want us to take a look at the future of nursing. The future of nursing as it was framed as an initiative from the National Academy of Medicine. So some guiding questions, and this is what I'd really like to do, is to have us think and feel through some things together. What is the future of nursing we've inherited? Sometimes we feel like when we inherit something, it's the here and now. But what is the path towards the future that we have inherited? And what is the future we've inherited? How are communities impacted by the priorities that nursing and nurses invest in? Right? How are communities, especially those who are historically excluded, how are they impacted by the priorities that nursing and nurses choose to invest in? What is the future we are leaving to current and future nursing students and their future communities? And when I say future communities, I mean colleagues, I mean folks they'll be caring for, which we typically kind of reduce in some ways to patient. If there's more than that, we can explore that. Their loved ones, their partners, their families, chosen in bio, right? So looking beyond just patients and just students, right? A little bit more whole in how we view community. And finally, how are we engaging learners in seeing the co-creation of the future as within their realm of responsibilities as well as their agency as something that's possible? Sometimes, you know, when I'm with students, with learners, I say, you're not just entering a profession, you're not just seeking a job. My hope for you is that you will see it as a realm of change, that you are part of advancing nursing. It's not just a profession you try to enter. And it's up to us as educators and folks in positions of power to not only just say that, but to say, when you voice your thoughts and your concerns, we will listen. So that's just a little bit of thinking towards the future, but I of course want us to look kind of at our roots and look at historical context. And I can, this quote, if anyone has not read James Baldwin, please read every single thing that he has written. There's one focused on teachers that I read every year before the academic year begins. The great force of history comes from the fact that we carry it within us, are unconsciously controlled by it in many ways, and history is literally present in all that we do. And something that happens through colonialism is we feel like history is there, the past is there, we are here, future is there. But that is a very linear, fractured way of viewing things, really, that doesn't promote relationalism. So this graphic, this could literally be an entire academic year, but we will kind of focus in on certain things. So when I say ancient and pre-colonial systems, oftentimes when we think ancient, we are asked by our educators to think about ancient Greece. But ancient civilizations are far more expansive than ancient Greece. So when we think about how our ancestors cared for themselves, what was health, what was wellness to our ancestors? How have certain ancestral ways of being and viewing the world been uplifted and protected? And how have some been erased? How have some been dismissed as superstition? So there are narratives that control what types of ways and systems in viewing the world and life ways are seen as valid and appropriate, and are deserving of still being with us and to be celebrated. On the bottom left is an ancient role of women, and particularly queer women in the Philippines, called babaylan, or spiritual healers. And so I want us to think all the different ways that our ancestors cared for each other. And you can fast forward, again, this is reductive and just some things I want to pick and choose to highlight here. But we can look, fast forward and look at contagion and miasma. How do we understand the role of noxious air, right? Kind of, if you've studied public health, right, or history of medicine and nursing, these are terms that will kind of spark some interest in you, hopefully. But we also see the primacy of biology. Linnaeus, at the heart of that is categorization, and at the heart of categorization is hierarchy. But we also see that racism shifts and becomes a pillar of modern science. I say modern because science has existed for millennia. There are ways of understanding the world around us, which we might now call hydrology, if you were to connect with the Kanaka Maoli in Hawaii and how they understand Mauna Kea and why they're fighting for that mountain, right? And so how we even define science has changed over the centuries in very particular ways. But we also see imperialism, thinking about empires, thinking about how countries seek to dominate other countries politically, through the education system, culturally, economically. And through imperialism, we see military, nursing, medicine, and education having very clear roles, as well as the church. And again, bringing it back to my own positionality and my experience and awareness of even the experience of Filipino nurses, there's a reason why Filipino nurses have been impacted in a very particular way by the COVID pandemic. Because of imperialism, my people were trained to become labor export kind of champions in a disturbing way. So now there are Filipino nurses practicing in over 50 countries around the world. So all these different front lines that wrap around the globe, and it's not just Filipino nurses, I'm just speaking from my own experience. And so we fast forward and see how biomedical model, which is so rife and alive and well today, has these antecedents. These are the roots. Imperialism and racism are at the roots of the biomedical model. So let's take a look at that a little bit. One thing I do want to say that's important about reckoning is what I have learned about colonialism and racism have come from lived experience, have come from my work being in solidarity, particularly with Black-led organizations here in the Bay Area, and Indigenous organizations and nations around here as well. But when you look at all of these books, and this article here by Dr. Barbie on the top right, Racism in US Nursing, the amount of wealth, of brilliance, of pain, of efforts to combat oppression. Not one of these books was I ever asked to read by a nurse. Whether it was a nurse educator whose course I was taking or a nurse who was a colleague, these were all works of brilliance that paved the way forward and have really shaped how I think about the world and how I view myself as a nurse and educator. None of these were asked or assigned to me by a nurse. And I think that is in and of itself a form of reckoning for us to consider. What do we see as fundamental to nursing education, to being nurses, right? So something for us to consider. I would love if medical apartheid or nursing civil rights or any of these were just, let's read this and let's get into it, not stick to a surface kind of book club. Let's turn that book club into action, into practice, right? So I want us to be on the same page in terms of levels of racism. And this isn't me assuming you don't know. I'm sure that you do have familiarity with this. I just think it's really important because I know that to become a nurse educator, this knowledge isn't required. It's not even rewarded. It should be fundamental, but it's not. So I just want to go through these levels of racism just so we're on the same page. So there's internalized, right? Members of a stigmatized group accept negative messages about abilities and intrinsic worth. And at the heart of the harm is this an acceptance of those limitations. Not feeling fully human, or that you have the right to have dreams, a right to a future, a right to self-determination. And part of this as well is rejection of ancestral culture. So all the ways that we allow the world to cut into who we are and to really have love and place value on our own roots. There's racism that's also personally mediated. So there's prejudice, right? Differential assumptions about abilities, intentions, etc., based on perceived race. And then there's discrimination, so prejudice and action, right? So actions towards others. And it can be intentional or unintentional. And ultimately it's about impact, not intention. And then we have institutionalized racism. Really different access, inequitable access to goods, services, opportunities, and that includes access to power as well as material conditions, housing, multiple forms of safety, high quality education, right, healthcare, and it's normative and it's sometimes legalized. And so with institutionalized racism, there doesn't have to be one specific perpetrator, right? It's built into the systems, policies, and practices. So Dr. Kamara Jones, the former president of American Public Health Association, she has a wonderful article about this for folks to check out. So we've talked about roots, historical contexts. We've talked about different levels of racism. I want us to look at colonialism next and then see how this has all shaped the biomedical model. So colonialism, I mentioned briefly before, it's really military, economic, political, and cultural oppression. So it is absolutely thorough in terms of domination of one country over another. And it's specifically for the extraction of raw materials, natural resources, but that extraction of raw materials comes hand in hand with extraction of scientific information and specimens. A specific type of colonialism is settler colonialism, and that's when the settlers invade and remain, which is what we have here in the United States. But at the heart also of colonialism is this assumption that we can take a whole, whether it's a person or the whole land itself, the continent, and you can divide it up into pieces and claim expertise and ownership. We have subspecialties. We're great and really effective at dividing human bodies, but also at dividing entire communities. Where have we chosen to build highways, for example, right? whose neighborhoods are then demolished, who is displaced over and over again. So that's you know, colonialism in and of itself can be an entire course, but I want to focus on those pieces. So now when we think about the biomedical model, I'll go over some of these, but I want us to see how they're connected to colonialism and how they have roots also in racism, right? So again, the biomedical model, reduction of the whole into parts, right? How do we deploy narratives of expertise in nursing and in healthcare overall, right, and health sciences? To what degree do we talk about emotions and the sacred and wholeness, right? So when we think about the institutionalization of biomedical model, we isolate, we believe in objectivity, and we believe that is the ultimate, and to be subjective is to be inappropriate or not quite scientific, not robust. But there's also this stripping away of context, right? We want to narrow our gaze to maybe unhealthy behaviors, or narrow our gaze to pathophysiology, or narrow our gaze to behaviors we can help patients manage, or narrow our gaze to specific, you know, organ system. But we also take on this very apolitical stance. Oftentimes we're socialized to do that, to outright say that this is my positionality, and with critical race theory means that we are going to dismantle oppression, and that is one of the, you know, the tenets of social justice. When we are socialized into apolitical spaces, that feels inappropriate and that feels unprofessional. So it precludes these conversations about change, right? So it's an optional framing to be political in the biomedical model. And so we also see that hierarchies are at the core of the biomedical model. If we were to map out, or if we were to ask nursing students, right, to map out which are the most respected specialties in nursing, what kind of nurses do we want to be? What might we see in that? What might we see? Where might we see psych nurses? Where might we see ICU nurses? Where might we see community health? And what does that tell us about how we are socializing our own nursing students, right? What competitions do we keep alive, and forms of hierarchy do we keep alive in nursing, right? So that's kind of a quick run through of historical, but also fast forwarding to the biomedical model. But I want us to look a little bit more closely at nursing education and the status quo. So I've done a number of research projects where I've looked at our foundational documents. And so we're going to take a look specifically at systems of power in nursing. So when we look at these foundational documents, really, scope and standards of practice, our social policy statement, code of ethics, ultimately, when we do a critical discourse analysis, we see individualism. It is rife throughout all of these three documents. We see calls for self-regulation. That in of itself is a demonstration of power, the assumption that we are capable of regulating ourselves. And it makes me wonder about accountability. Who are we accountable to? And how is that built into the work that we do as nurses and as nurse educators? And the word professional or professionalism appears hundreds of times across these three documents. And so when we look at professionalism, what does that mean? So ultimately what I see in these documents is a discourse of status, it's a claim to status, hierarchy and control. We can get into that more later, but that's ultimately, those are what I see when I do an analysis of those documents. But we also, because we're in nursing education, have to look at the essentials from the AACN, and I know that they put out a draft of the next version. But there's a call for liberal education, but I don't see it as expansive as it could be. Where are the humanities? Where are the arts? Again, we narrow epistemologies. We narrow, you know, how we know what we know, and we only kind of focus in on particular ways of knowing what we know. And that's through colonialism and racism and the biomedical model. And when we think about the calls to looking at policy, they're all rooted in healthcare. But we know that healthcare policy itself is not nursing. It's not the only aspect or type of policy that impacts how well we can be, how healthy we can be. In this document, there's also this focus on interprofessional communication. Again, that word professionalism and professional. And that narrows down who we think we should be partnering with, who we see as experts, who we see as necessary to promoting health, right, to the practice of nursing. And again, professionalism, it is throughout this document as well. So what I see in this document, which is tied to our accreditation, is a narrow gaze, and it really focuses nursing into healthcare. And I would like to argue that nursing is healthcare and beyond, and it must be. And so ultimately, this is also a document that is focusing on a claim to status over accountability. And that really concerns me. With this newest draft of the essentials, ongoing contradictions are there. So it has this statement here. Professionalism encompasses the development of a nursing identity, embracing the values of integrity, altruism, inclusivity, compassion, courage, humility, advocacy, and caring. And it's a long list of really beautiful values and ways of conceptualizing nursing, but there are contradictions here. Again, because professionalism is a claim to status. How does that fit with humility? What types of advocacy are championed and framed as valid within a view of professionalism? And because my background is in community health, I have a, when I see population health described in this way, it makes me take a moment to really think, well, what are we saying here? Population health spans the healthcare delivery continuum. So again, we are narrowing our scope to focusing on healthcare delivery. And what I see here is that community-driven health is not here. The responsibility to be responsive to community is not here. And something that I've started saying and chatting with students about more and more is, if nurses and nursing are more concerned about people when they are sick already, what does that say about us as a profession? I know we have our different levels of prevention, but at the heart of nursing is this push to cleave it to healthcare and to hospital. So what does that say? What does that say about our future and what else we can do? Right. So I want us to look at the system and industries of nursing education. So imagine if we were to put nursing students at the center, really fully at the center, in the communities that we care for at the center, right? And then kind of look more upstream and say, what is going on with our departments and schools of nursing? What are the living conditions in which we're asking folks to learn, and we're asking folks to trust us with their care, right? And then we move even more upstream. What are the gatekeepers? Who are they gatekeeping? How are they gatekeeping? Through practice, education, research, and policy. And then what are the institutions that serve as the pillars of all this? And it's not just education, it's not just healthcare, it's also the media, the economy, the state, etc. And finally, infused through all of this, what are the systems of power at play? How are oppression and privilege protected in the status quo, right? So we have these organizations here, but I want to say that as a nursing education system, we are also upholding certain industries. We're upholding textbook and publishing industries in particular ways. We're upholding education surveillance technologies in certain ways, as well as test prep and other industries. So just thinking about us in that way, how have we in nursing education positioned ourselves to protect or rely on certain industries, right? So talking a little bit more about status quo, I'm gonna share a little bit from, this is from my dissertation. I did an interview with nurse educators in BSN programs throughout California. So I'm curious to hear how this lands with you all in Michigan and the lands of the Anishinaabe. So what we see in the status quo of nursing education are harms of colonialism, racism. From this standpoint, education is the reproduction of inequality. And with reproduction of inequality also comes resistance, always resistance to that. And so what I found from nurse educators who are more likely to perpetuate the status quo for different reasons, there's an emphasis on equality. Treat everyone the same. To do differently is actually offensive. It feels wrong. Individualism, there's a focus on individuals. And then it's fine to say, let's increase awareness of health disparities, but that's it. We're glad that we're aware and that we've raised awareness. And then there's this emphasis on withholding judgment. Let me not share this racist thought, or let me not think about how I'm judging this person's appearance and linking that to deservingness of high quality care. And so some of the teaching strategies that support the status quo include constructing diversity through lecture images, right? So let me Google a Muslim nurse. Let me Google Black midwife and put that on the PowerPoint slide. Boom, magic, we have diversity. And then stopping there, right? Other teaching practices are around culture. Do we essentialize and conflate culture with race? You know, those tables, the transcultural nursing care tables that do a fine job of conflating culture with race. If you have a Black patient, this is what you should do. If you have a Chinese American patient, this is what you do. For the Mexican patient, this is what you do. A patient from Appalachia, this is what you do. And then another piece here is sometimes the term or concept of culture might only come up in conversations when maybe we're going over a case study and the patient doesn't speak English, or a patient who is a person of color, or who isn't Christian. So when do we even talk about culture? And what does that communicate to our colleagues and also, of course, to learners in our classes? And something else that's a teaching practice that supports the status quo, right? We talked about isolation, talked about silos, hierarchy. When we relegate issues of current events or justice or broader context, when we relegate those to community health nursing, if at all, that's something else that also supports the status quo. Okay. And I will tell you, every year that I've been teaching now for almost 9 years, there are things that I did years ago that I would never do now, right? So all of this is part of the journey of learning. But part of the status quo is, again, this focus on competency and mastery. Separation from relationships and context, a narrow conceptualization of, you know, what knowledge and skills count, right, will help you be a good nurse. And something else that I've seen also is within this framework, cohorts exist in name and a course roadmap, but not necessarily in relational practice. How do we see cohorts of students as community? Right? How do we nurture the relationships that they have with each other as also fundamental to their educational experience? But we also, through this, see a lot of fear and silencing, right? And this right here is coming out of a current research project I'm doing where I'm interviewing nursing students in pre-licensure programs. There's a fear of complexity. There's a fear of ambiguity. There's a fear of having discussions and dialogue that can go anywhere, that will be organic and student-led, right? There's a fear of making a mistake or being wrong. And the fear that what happens, right? So for example, we have conversations and the student will say, what happens if I were to misgender a patient? So I'm not even gonna go there and talk about pronouns. Just ask me what your name is and I'll tell you what my name is and that's it. And so the fear that keeps us from doing that learning and that practice. And ideally, you know, the practices where we would have, you know, maybe in SimLab or different courses in pre-licensure programs is where can you have that practice? Even in doctoral programs, right? How do we learn how to apologize in really genuine, transformative ways, right? Silencing of classmates, of faculty, of patients. And what happens in this system is that folks who are curious, folks who are creative and imaginative and voice those and verbalize those and demonstrate those and have a critical lens are viewed and treated as a threat or as a risk. And so I've spoken to faculty who their health has suffered, their well-being and sense of self have suffered because of challenging and being curious and nurturing creativity in relationships and in learning spaces. So I want to highlight a number of quotes from previous study and a current study. So these are from a current study that I'm doing. So I've completed 30 interviews and I'll probably be stopping soon, reaching saturation, but I want to uplift students' voices here. I felt like the school really is protecting its statistics more than anything else. That's what it values. Can we say this many people pass the NCLEX the first time? I want them to see that we are bright, we meaning students of color, and we do belong here. These exams have nothing to do with belonging in nursing or even being a good nurse. They all want us to be this one way. They want you to say yes. They don't want you to question. If you do, it's like you're trying to challenge them, but you're really just trying to get a better understanding. You want to have like-minded people around you. You want to feel like you can take off that suit of armor and have a place to breathe and be yourself. I feel like my suit of armor is getting another layer every year. So if it's hitting you a certain way, feel free to take a breath. Some more voices here. When I bring up that our patients are receiving unequal care, classmates tend to roll their eyes. I try having conversations, but some of the white students roll their eyes at me. Harm can be in the classroom, but even more is the harm that's done to our future patients. I think our faculty of color are unsafe. White students constantly question the information. They're at the will of the students, and on top of the work they do, they become lifelines for every student of color they teach. All of us are looking for a lifeline, someone to hold on to and help us feel welcomed or safe. And the final student voice here. I was misgendered the entire semester. It's not just nursing school. It's not just being trans, it's everything. The self-care that goes into making sure I'm mentally, physically, and emotionally healthy enough to get through this program. Now, I also want to include faculty voices here. Again, feel free to doodle, do what you need to do if these are hitting you a certain way or relating to them. It feels so friggin' incremental and so small. It's easy to feel demoralized and like you're on an island and don't have enough people. White women are still spinning in their own circle. I try to go into those spaces and voice opposition to some of the nonsense, then I get discouraged because they just go around and around. In this profession, you've got to find your allies and work. It would take real savvy to guide a discussion. We're focused on, here's how the body works and the right way to take care of it. We don't have practice to say, I'm going to guide you and encourage you to think about your thinking. And finally, students are focused on disease process. You only can slide a little bit of social justice in there. That's not what they're there to learn. You've got to meet them where they are. So as we, excuse me, consider these quotes, we can map out the systems of education here. We see accreditation, pass rates. We see how are we supporting cohorts as community, as spaces where folks are expert and are learning from and with each other. So folks aren't rolling their eyes at classmates when they're pointing out unequal care. When we say students are focused on this, not this, we're gonna meet them where they are. Yes, and what else, right? How else can we also nurture forward-facing, future-facing work, right? So let's talk about mapping for change and then have some conversation. So when I think of that, I think of anti-racism and I think of education as the practice of freedom. I really encourage, if you haven't read Bell Hooks yet, Teaching to Transgress. I think it's such a powerful book. So much of this work that is framing our future is from the brilliance of Black feminist scholars and thinkers and poets and artists, right? And so some statements from Bell Hooks' book. As a classroom community, our capacity to generate excitement is deeply affected by our interest in one another, in hearing one another's voices and recognizing one another's presence. So that alone quickly cuts through that, transgresses even the physical built environment of our lecture halls, right? They're facing one way. So there's an assumption that one person has the expertise, right? And then this other statement, the classroom remains the most radical space of possibility in the academy. And I mean, just reading that makes you feel goosebumps. I think, what is gonna happen next time I'm with students and we have conversations? How can we meet learning objectives and still dream about the future and say, this is what society needs to be healthier, to be just, right? So within this, there's an emphasis on equity, relationalism, accountability, and action, right? So within this, when we think about teaching practices, there's a collective responsibility to address and repair harm. It's not just for folks who are historically excluded to carry that labor and then to tend to more privileged folks' emotional or cognitive dissonance. That's really part of this as well, as who's doing the work and what is all, there's a range of work to be done. Beyond curriculum to really what's internalized, right? We talked about the 3 levels of racism. If we don't tend to what's internalized and connect that to what's institutionalized and the systems that back those up and our pillars, we're missing parts of that puzzle. This work needs to be beyond the here and now to the future. How many generations ahead do we think when we think about our families, our loved ones, future patients, future nursing students? And ultimately, this is about praxis, right? This iterative process of reflection and action. And I think ultimately, healthcare and nursing will not be healing unless we make that so. And part of that needs to be an emphasis on praxis. So, and I so appreciate visual scribes now. I've only been in a couple of meetings with them, but this is one product of a visual scribe sitting in on a meeting focused on Indigenous cancer mapping in British Columbia. And when I think about this, I think, well, nursing, we would normally say, well, what can we do at each stage of this journey, from pre-diagnosis to the next chapter? But I would love for us in nursing to say, how can we make this entire process and journey in and of itself better and not necessarily have these silos? What else can there be? What are other journeys through health that we can nurture, right? And I think that comes back to our guiding questions. So how might we shift from a biomedical model foundation of questions to equity focused, right? So instead of saying, you know, how do we reduce health disparities, we can shift to how do we eliminate injustices that produce health inequities to begin with, right? Instead of focusing on, you know, what interventions are necessary, we can ask, well, what kind of collective action and structural social changes are necessary, right? And it goes on and on. I will also say at the very end on the bottom where it says, which government officials, researchers, or media personalities best understand the issues? This is the one where it asks us to transgress the notion that interprofessional collaboration is collaboration that's most important. Because this asks us to say which community residents and grassroots orgs can best define the issue. Because most oftentimes, those most directly impacted have solutions. We just need to kind of stop and listen and invest in them, right? So some teaching practices I think we can, you know, explore together are really there to serve to disrupt gatekeeping, right? So let's have, you know, a close look at our admissions and hiring requirements. Let's look at the learning objectives that we uplift. What are the priorities of our committees? Student Affairs Committee, Faculty Affairs Committee. What is the type of education that we want our students and future nurses to have? You know, what are the prereqs? What are the skills that we say are fundamental to nursing? Because I would say, going back to the notion of a just transformative apology, that would be a huge one. Media training, what kind of media training can we also support with students? You know, how students can be in relation with each other and not focusing specifically on certain types of transactional relationships. How do we scrutinize our accreditation standards throughout the pipeline? How can we center storytelling and accountability and bravery in our learning spaces? And finally, how can we connect with broader movements? Because I would say to dismantle oppression is at the heart of promoting health and wellness and safety. And so we can expand the imagination and norms of nursing from this, which is what happens if you Google nursing, if you Googled it 2 days ago, to this, to what are the ways that we use our voices. The bottom left where I have the city council, a number of students in my community health clinical group did their public comments there. I required them to do a public comment as an assignment in clinical, and they chose that city council because they were reviewing a housing proposal near a Superfund site. We also have students who said, you know what happened when Don Wooten came out as a whistleblower against forced sterilizations at a detention facility? We want to host a vigil. And so this was all led by nursing students, a vigil photo on the bottom right. How can we stand with Indigenous nations and say Indigenous sovereignty, climate crisis, environmental racism are all connected and we have a role to play in all of that, right? So much to say here. The Black Maternal Momnibus Act is brilliant and it's beautiful and it's a great model for us to think about all the ways we can call for change, right? So when I think about you all, where you are, how are you engaging with each other and with learners to think about these different issues that are happening in Michigan historically and today? How do we see these as ways to examine our place in the world as nurses and as community members, right? You have amazing resources here. And also, you know, immigration rights, housing, there's so much here, right? So how are you engaging with local communities as a way to connect with the broader world? And then finally, what are the power dynamics at play? Do you see yourselves advocating for service or empowerment, solidarity? Is charity in there? What does advocacy look like when you talk about it? And how does this position nursing students and patients and nurses, future nurses and future patients, right? So just to close up this piece, Lilla Watson, Aboriginal artist, said, if you've come here to help me, you are wasting your time. But if you've come because your liberation is bound up with mine, then let us work together. And that's, I'm gonna close there. Salamat everyone, thank you for listening, and I look forward to conversation.
Thank you so much.
Thank you.
So would you prefer that we have comments put in the chat, or would you prefer that people just speak?
However you all want to voice yourselves, I'm down to hear whatever, however.
Okay, we can have people put their questions in the chat. Well, while we're waiting for the first question, I wanted to ask, what advice do you have for programs that are looking to move in this direction, in a similar direction?
Yeah, I appreciate that. Actually, in my Department of Nursing, we just launched a Dismantling Racism in Nursing Education Task Force. And so we have kind of two prongs there. One of them is, let's take a deep dive and look at all of our syllabi. What do our learning objectives tell us? What are the topics folks are sharing? How are you defining culture? How are you defining diversity? And just being real about the theoretical framework of critical race theory shaping that. So I did that analysis. I analyzed all of our programs, syllabi. And then we're also doing a climate survey. We have to know how students, staff, and faculty are experiencing nursing education as a racist institution, as a racist program. That's just a shared assumption, is that racism is here alive and well, as well as patriarchy and transphobia. So how are you experiencing it? And then that's shaping our strategic plan. We're also taking a deep dive and looking at our admissions. All the data, looking at all the policies and practices. Is TEAS tests, should that be required? There's a long history of standardized tests having racist roots. You know, what is our stance on that? So we're taking a close look at all of these things. And it's a partnership among faculty, staff, and students across all of our programs, pre-licensure, post-licensure, and masters. And it's exciting, it's also uncomfortable, but it's the work we need to do. And so we have one of my colleagues co-chairs the task force with me. She has been doing monthly critical race theory workshops with faculty specifically. So those are some things. But I would say through all this, care for the most historically excluded. So care for Black women in your program, in your among your students, among your staff. Listen and believe, and step back and listen. Because healing has to be part of this. We can't tokenize folks throughout the whole process of bringing DEI to life, right? And justice to life. So those are some things.
Well, thank you. We do have some questions in the chat. The first one is from Dr. Lisa Kane-Lowe. As you explore the challenges of accreditation, do you see opportunities to do the work from within the accrediting bodies or externally in partnership with the stakeholders across the school?
Yes, I would say all of it and everything in between. Something that's really interesting that I've come to bear witness to, especially just being surrounded by educators and being in institutions of higher education, is sometimes we really believe that sharing evidence will change things. We have mountains and decades and centuries of evidence of harm, and they're still the way they are. So there have been times where myself or colleagues I trust and believe in and say we need in nursing will hold folks accountable and say, This is a document that has really, it is perpetuating harm for nurse educators, for nursing students, for future patients, current communities. Here are a couple of bullet points from these articles. You don't even have to read them. Let me paraphrase them for you with the citations. And let me give you a couple of pointers of ways to maybe address the harm and to fix it, and let's do better. And folks will still say, we don't have time, we need to keep moving. There's a lot of folks in this group that maybe don't understand this quite yet, so we're just gonna move on. So even in the face of folks providing concrete examples and recommendations, people in positions of power will still say, it's okay for me to not know, and I'm just gonna keep going. So that takes way more than sharing evidence. So I think we need all of that. We need all the different types of organizing. I'll just call it organizing. It's one reason why in that Minnesota Wheel in Public Health, it's not called community assessment, it's called organizing. I love that. Because it's about change. And so what moves people to change? That's the ultimate question. Sometimes it's what can we do to organize and change, but what do people in positions of power need to change? How much, and it's a hard question to say, maybe I don't know, and maybe I need to step aside. Not, I don't know, and it's okay for me to not know. There's a lot there, a whole conversation. But thank you for that question. So we need all of it. We need possibilities, we need alternatives.
Well, our next question is from Dean Hearn. So many areas that need change. As we move forward, are there things that nursing education is doing well and that we should preserve?
You know what, there's something that I think, I talked about cohort. Do you all kind of follow a cohort model at University of Michigan, at least in your pre-licensure? Everyone sticks together and goes through the same. I think there's a real strength in that, where students come out as already a community sometimes, moving out into the world. I would say nursing has become better and better at saying these are some of our values, but I would say they're still rife with contradiction. I think right now I'm concerned about performative statements of commitments to justice. To be honest, I think because of my work, I've come to get to know nurse educators in different spaces in North America, where people will put out wonderful statements, but they are still being targeted when they speak up to advocate for students of color or students who are being targeted in some way. But I think nursing is flexible. Nursing is beautiful in that way. It's just a matter of where do we shift that flexibility and that ingenuity. But it is also, I have deep love for nursing. That's why I also am very critical and know that we can keep doing better. But I think one of the reasons why nursing is so appealing and beautiful is that we have that flexibility. Nursing can be so many things. So why do we narrow ourselves, right? When we think about focusing on healthcare or focusing on hospital. We are nurses wherever we are, right? Whether we're in scrubs in a hospital, in a classroom, in a sim lab, at the Bay Area Air Quality Management District board meetings where I bring my students, we were always nurses. And so I think it's a disservice when we separate or silo out too much. Thank you for that question.
We have some comments about appreciating the thoughtful analysis of language we use in writing our documents. Words matter, from Dr. Freeze. From Shika Calabor, we have, thank you for having me. A friend forwarded me this event that I had to join. I'm an NICU nurse who is currently at Harvard getting my master's in bioethics. My classmates and I are working on a similar project to the task force you mentioned. I'd love to connect in the future.
Email me. Email me. I mean, to be honest, relationships, that's what's going to get us through. I mean, genuine relationships where we can hold each other accountable. I saw you do that. What was going on there? Or I saw that in your article. Let's have more conversations. Read this book, right? And so accountability is love and action, it really is. And so when we're afraid of making mistakes, it keeps us from seeing who we're accountable to, right? So our chief diversity officer, at the university, back when we were still meeting in person during our diversity advisory council meetings, she would always have an empty chair in the middle. So we always knew, who are we thinking about here? We are centering students and marginalized, excluded students in particular. So what are the ways that we keep voices and the presence of folks that we're working with and for with us, right? So I appreciate that. Just email me.
Will do. And I'm heading off to another meeting, but thank you so much. I feel like this is the content we were all looking for in nursing school, and I graduated in 2018, which is not that long ago. So I really, really appreciate your talk, and you'll hear from me, and I hope
yes,
we can
thank you. We'll Zoom.
Yes.
Take care.
Bye.
Bye.
All right, our next question is from Michelle Toralba. I'm a first-year nursing student, really passionate about social justice issues, but what advice do you have for those early in their career like me who are striving to combat racism and colonialism in nursing practice?
Well, I would say it might feel early to you, but it actually might not be. You know, I didn't really jump into this work. Again, never saw myself as an educator, never saw myself as an organizer. Now I'm a chairperson of a grassroots org. Until maybe 6 years ago, because I was socialized to not view that as professional, or not view that as desirable. My parents didn't come to this country so that I can end up on the news, and they're like, what are you doing? How are you using your voice? So I know I bother my parents in some ways, and that's another issue to talk about, as well as what does change in professionalism look like when we're children of immigrants, or when there's a lot of weight on us for how we represent our people. But I would say trust in that learning happens everywhere. It happens everywhere in the books you read, in the relationships you have. Seek out what challenges you, right? So when I was in my master's in public health program, growing up in a, we didn't speak English at home. It was very conservative in a traditional child of immigrants way. Very Catholic, Filipino Catholic as well. But I learned so much when I was doing harm reduction work with sex workers in downtown DC. So when I have on that slide voyeurism, that's me speaking to my past self, because I had to challenge myself with that. So I would say soak it all up. Don't assume that learning only happens in formal schooling settings. There's so much online right now, amazing webinars and free conferences and amazing blog posts by scientists. We can connect on folks you can follow on social media, amazing thinkers and artists on social media. Because I would say what can guide you maybe a little bit in terms of social justice is, for me, a guiding question is, or stance, is the more I know about myself and each other and the world, the better I am as a nurse and educator. So you will find for yourself your guiding question or questions for how you approach learning. Sometimes with this colonial linear mindset, we think, oh, if I veer away, it means I'm dropping that, or that was a waste of time. But we need all of that. Thank you so much, Anthony. So those are just some things I would say. In some ways it might be early, in other ways you've probably been holding on to these ways of thinking that are needed in nursing. And to give yourself space in the emotional dimensions of learning as well.
Thank you. I'm actually also the daughter of Filipino immigrants as well, so I really relate to the whole imperialism and colonialism shaping your own identity, but definitely learning from you about like how it affects like my future career as a nurse has been really eye-opening, and yeah, thank you so much.
Thank you. Feel free to email me. We gotta take care of each other and connect and have these conversations. Yeah, thank you.
Our next question is from Dio Davis. How can we begin to shift the focus of nursing to health promotion, prioritizing underprivileged communities, and taking an upstream approach when there's so much funding and focus on disease care, hospitals, and institutions?
Oh, there's so much there. There's so much there. So there are a couple of things, because we need multiple approaches at the same time. So we can look at how the funding of research shapes career trajectories and what we prioritize and the questions we ask, and the research that, because research also shapes how we teach and what we think are valid ways and approaches to pedagogy. I think there's a need for also, I know, we have mountains of evidence of health disparities and health inequities, but I think there are ways for us to also keep describing, right, descriptive research, but that's very critical, right? So if we were to map accreditation standards to changes or lack of changes to health inequities, what might we see? So what are the different questions we need to ask in our research? And then part of this is also diversification of the workforce. This is throughout the pipeline. Because when we only have 1 or 2 Black students in the cohort, they're being asked whether they want to or classmates mean them to, can you please confirm for me all these stereotypes about Black people I've ever heard? You are an Indian student. Can you speak Hindi and translate, be an interpreter for my patient? I don't speak Hindi, I speak Punjabi. So there are all these assumptions that we bring, and that shapes the experience of marginalized students. And so I worry about retention, not just in programs. I don't worry about attrition just in programs, but attrition from nursing overall. So I think it's caring for folks that we have, it's bringing in folks with very rich ideas, and it's also, how do we hold to account folks in positions of power? What is the role of the AACN? What is the role of NCSBN? Is it NCSBN, National Council of State Boards of Nursing? What is the role of CCNE, all of our accrediting? Those are industries. They're not merely, checkpoints of quality of education. They're industries. And so part of this is us seeing who are we investing in and what are we investing in. So it's a soul search, but also a soul search that folks who are excluded should be doing for those folks. So it's all multiple directions, which is why we need everyone in this. But also it shouldn't be on the shoulders of nursing students to carry all of this. Though I do talk to students about student-led movements and the power of students, right? So there's a lot, but I'll stop there.
We have another question from another student. Oh, Vivian, you wanted to speak? Go ahead.
Yeah, so I think the next question is from me, and after typing it, I realized that you might have addressed this. It's just because I came to the meeting halfway through it, but it's somewhat long, so I'll just read it. So you pointed out the difference between educating nursing students on the existence of health disparities, and if I'm remembering correctly, and then educating them on changing health disparities. So from my experience thus far, so I'm a sophomore as a student, I find that the emphasis seems to be that they think that nurses should just take in this information so that they can have sensitive care, and that seems to be where it ends. Yeah, so I was wondering, do you think that is enough? And I feel like you'd probably say, no, that's not enough. So then therefore, what do you propose? And then what exactly is the nurse's role in intervening in health disparities? And for students who feel like health equity focused classes are kind of irrelevant to our nursing courses and kind of more classes that public health students should be taking, how can we empower those kinds of students and change their...
Thank you for your really thoughtful question, Vivian. And this is, I can hear this one is born out of lived experience, right? So I would say a couple things. What is nursing? If we perpetuate nursing as healthcare that is hospital-based, it is no surprise that folks who enter and seek out and make it through all the hoops and get into nursing school say, no, that's public health, this is nursing. And that's a perfect textbook example of colonialism, of saying this is this, that is there, that is not what I came here for. But also the assumption that what I came here for is the only thing that nursing can be, right? So imagine, I'm not saying, TV shows are gonna save us, but imagine the power of the media, of who nurses are. If we were to look at Grey's Anatomy, all of them are all hospital-based. They're all problematic in multiple ways, but also inspiring in other ways, I guess. I haven't watched one in years. I stopped watching Grey's Anatomy in the second season. I couldn't take it anymore. But part of this, so it's expectations. What are our expectations? When education also is cleaved to the idea that course evaluations shape our careers and well-being, do we want to challenge students to say, you came in here with this one idea, okay? Let's also expand and say, this is also nursing. This is also future thinking. So saying the jobs that we have today aren't what we need nursing to be for a future where justice is just the default, right? So how forward thinking are we? Accreditation standards standardize us and aren't forward thinking. So we have to question accreditation in multiple ways and assessment in multiple ways. And also, there are lots of things. When we think about what shapes what you think matters? Do you have to live through it in order for you to think it matters to you? And so I think that's why marginalized and minoritized students end up taking on that role in certain ways, because they see that if I don't tell them that I'm also a human being who grew up in East Oakland and I have these dreams, they might not ever know anyone who's a Black person from East Oakland. So I take on that pressure. So all the cohort dynamics are rife in your question. And yes, you're correct about my answer saying it's not enough to be aware. So for example, one way I tried to do that, I'm still learning. I was a guest lecturer in the community health theory course yesterday, and every single small group had to look at, so one group looked at the Zapatistas, principles and, and practice. Another group looked at the Black Panther Party's 10-point program. Another group looked at the Alabama Amazon workers list of demands. Another group looked at the Poor People's Campaign, the 14 policy priorities for Biden's first 100 days. Another looked at, so the California Domestic Workers Coalition launched a whole new campaign because their bill for health and safety for all was vetoed by our governor last year. They launched it yesterday. I asked students to watch a snippet in the 3 languages of that webinar and to see what their demands are. So the overriding assumption here is that nurse educators don't need to tell students directly what folks are calling for. They can do it themselves. They can watch those videos, they can read those articles, look at those petitions. And now let's say if we're really committed to a healthier, equitable nation, it's not only going to happen through healthcare, that's crisis care. We're going to listen to workers, we're going to listen to women, we're going to listen to queer, trans, gender nonconforming folks and see, this is a beautiful article by Dr. Monica McLemore and a number of other physicians and nurses, Dr. Karen Scott. It's called An Inconvenient Truth. There's no solution to the Black maternal health crisis that Black women don't already have. So there's also this assumption that we got to discover something new and be super innovative, but folks who are directly impacted have the solutions, and they've had them for decades, if not centuries. So how can we stop and listen? So whenever we can, let's say, what is the role of nurses in challenging poverty? Sometimes I know, and I have this too, and I know students in the courses I teach experience it, is this hopelessness or a fear of complexity and ambiguity. That's too big. Poverty? Why are you asking us to look at that? But then I will say, look at all the different ways poverty is protected. Let's look at policies, let's look at practices, and let's look at Reverend Dr. Barber and the Poor People's Campaign and say, what have they been doing day in and day out? People are doing the work. Let's support them and join and learn, versus feeling like we have to do it from scratch. Because no one is doing it from scratch. Folks have been doing it. So I think part of this is, and I have the privilege of knowing of these examples, because these examples of hope and organizing and radical change aren't covered in textbooks or mainstream media. And so this is really, so we also have this group here called the Anti-Police Terror Project. And it was co-founded by a nurse. And so they have been instituting a mental health first approach where do not call law enforcement, call folks who are trained in de-escalation and mental health from a loving and just way, not a fear-based, let me punish you way, or let me other you. And it's going well. It was launched in Sacramento 2 years ago, and it was being launched I think it was launched last year in Oakland. So put those folks front and center. What are they asking for? And now let's say, how can nurses support? Because awareness is powerful. I know knowledge is power, but action is, that's what we need. That's what we need. And action can take all forms. It can even mean having a challenging conversation in a classroom, or having practice, apologizing and moving forward in a sim situation, misgendering a patient, or saying something that's racist. So it can take a lot of different forms. Giving public comment. Reflection is also an act. There are multiple ways to move past awareness.
I have a question from Dr. Patel. I recently learned that 4% of US nurses are Filipinx, and over 30% of COVID-19 nurse deaths in the US have been Filipinx nurses. Can you talk about the forces shaping this? And she happened to learn that when I spoke to the president of the Philippine Nurses Association, I hadn't heard about it otherwise.
Yes, thank you for that question, Dr. Patel. So that's rooted in imperialism. At the turn of the century, there are actually a number of American public health nurses who went to the Philippines, and they completely, with the military and physicians, transformed what healthcare looks like in the Philippines, and it really shifted it to being very gendered. And so it was seen as a form of, women can do a little bit more and have this new role. But ultimately, it was a way to create a steady flow of labor export. So in addition to certain electronics, human beings are the main export from the Philippines. And that continues today. And so that's why we're in over 50 countries. And so when people talk about the front lines, I could say there are many, many front lines for a lot of folks of color, and that it has impacted Filipino families in a particular way. So when I say multiple front lines, it's not just because we're in 50 countries, but also you can have a loved one who's a nursing student here in the States. You can have a loved one who's a physician or nurse or nursing assistant in United Arab Emirates, in Holland, in UK, and in the Philippines. And you can have all of that in one country and one family. And so that's where we when we talk about policies now in community health, I ask students to look at trade policies. I ask them to look at what are the priorities of particular dictators, and what happens when you're an impoverished, exploited nation. What are the choices you're forced to make? And we can say that about school systems that are divested from decade after decade, and then their partnerships with Coca-Cola. I mean, so it's just, it brings us to a lot of different parallels. But yes, so Filipino nurses are grappling with that in particular ways. And right now, as a icing on the cake, I think as the Department of Labor is in talks with Germany and the UK in exchange for a certain number of COVID vaccine doses they're willing to trade and send Filipino nurses. So an egregious form of labor export. And we know our immigration policies and all of this American dream wealth is from exploitation of multiple peoples. And that's just, it's one example of it. So yeah, there's a lot there. Thank you for that question.
We have one more question from Sarah Hendricks. Says, I've been thinking a lot about this and having conversations with colleagues. Do you see allies doing this work in medicine as well?
Yes, actually, one thing that's interesting is in medicine, they started holistic admissions quite a while ago. That's one step to looking at being a little bit more inclusive and targeted in admissions. But to be honest, we're all struggling. I mean, if you look at that JAMA podcast that has been blowing up on Twitter, if folks have listened, there are these two physicians, and one of them said, I don't want to use the term racism, it makes me uncomfortable. I think that was one of the phrases, don't quote me on that. But I think there's beautiful work coming from interdisciplinary teams, and no surprise from Black birth workers, doulas, physicians, nurses, midwives, health affairs. There's this new article that was last year, Dr. Rhea Boyd and others, a new standard for publishing about racism. So it's happening, and it's being advanced primarily by Black feminist scholars and clinicians, and allies as well. There's a lot of work to be done. I know that there are folks who are, I think it's in the NIH. The NIH put out a call for public comments on how to address racism in the NIH's priorities. And I think that those comments are due April 8 or April 9. So those are calls that I ask students to do as assignments. So back when the Future of Nursing report was actually still accepting public comments and statements, the final assignment of every community health nursing class I taught was a letter, an issue brief to that Future of Nursing task force. I'm sure they were bothered, like another batch of assignments. But those are real life forms of advocacy and calls for change. So as much as our assignments can be living examples of advocacy, I believe in that. But there are folks in medicine, absolutely. But I would hope that when we think about centering patients and the health of society, that we would work together in nursing, health sciences, mental health, all of these disciplines. That would bring us to the whole, right? Even artists, writers, that would bring us to the whole where society and people, not just patients, are centered. Yeah.
Dr. Coleman-Burns says, do you know the work of Flo Kennedy and her work in the 60s and 70s with sex workers in California? I so appreciate how your studies shows up in your language and how you discuss the concepts. Thanks to you and for who you are.
Thank you so much, Dr. Cole. Oh, okay, that gives me goosebumps. Yes, we can learn a lot from how we legislate, how we talk about sex workers, even how that relates to human trafficking. There is so much that we could say about that. And I learned about, I would say one of my primary lessons about care and love as core to nursing has been with sex workers I've come to know. And it really helped me challenge notions of voyeurism. When I first started working with sex workers, it was one of those, wow, look at what I have access to learn about in this world, how fascinating. I did not see them as human beings when I first started doing that work. It was much more, whoa, what is going on in this world? What have I not been exposed to? I was censoring myself the whole time. And I really had to do that work. But yes, Kennedy's work is, yes, thank you for uplifting that.
We have a comment. I appreciate from Dr. Patel, I appreciate how clearly you illuminate the challenges and what we are up against. I also appreciate the examples you share from your studies and experiences that help us to imagine a just path forward. Those examples are such a helpful part of this presentation, as well as how you challenge us to reframe the problem. Very powerful work. Appreciate you and all the work you've put in.
Oh, I appreciate that. When I am invited to speak anywhere, I still find myself uncomfortable. I feel like, am I taking up space? There are folks there at your institution doing such amazing work that I know about and that I don't know about. And so I always worry about how I'm using my voice, and always just, I'm here on the shoulders of so many. So it's an honor to meet you virtually, to be here.
Well, and so many people in the chat have said, thank you so much, and they appreciate the discussion. So I will make sure to save all these comments so I can pass them on to you.
Thank you.
Well, we do have about 10 minutes left. Are there any more comments, or is there anything you'd like to wrap up, Dr. Valderama-Wallace, at the end here?
Sure, if there are not any other comments or questions?
I do not see any other comments at the moment.
Okay, I would say hope is a practice, it's a discipline. And so I would ask us to center hope in the work that we do, without washing away the challenges. But how do we instill hope when we're asking each other and ourselves and learners to delve into all of this work? When I think about education as a colonial project, it also asks us to look for instant gratification. I got an A, or vital signs have improved, labs have improved, but this is a long, protracted struggle. But the more that we're in it together, we will see the victories. And this is why I'm here. I believe in nursing education and its responsibility and its promise. And so I would love for us to be able to gather at some conference or some gathering in the future. But I so appreciate that you're interested in this topic, and I thank you for all the work that you all have been doing. I wish I could hear more about what you all have been doing, but I am hopeful.
Thank you so much. I mean, I've been blown away by what you have shared with us today, and with so many who were in attendance. So any other last comments for at the end? We have a few more minutes.
No, I just, you know, as a woman of color and as a person doing DEI with my own journey, my own connection to a colonial past that defines who I am in my role as a human being and in my role as a, you know, DEI leader, I find a lot of breath and space in the opportunities you're creating for this kind of a conversation to unfold. I think you are very powerful. I think your presence is incredibly healing. And I am so grateful for the depths that I know these kinds of questions carry us to. And you've done so much labor. So just thank you for all you are and all you do and all you bring. And if we can support your initiatives, your work, your voice, your life, that of your allies, you know, your collaborators, you know, consider yourself having a home at our School of Nursing too. Thank you so much.
Thank you. Oh, you give me goosebumps. This is the relationalism that we need. Right.
And if I could, I do so much want to underscore for the essence of what you're saying about the dismantling of the canon in terms of looking at those essential documents. That's scary to many folk. And so, you know, as a person in this field for many decades, it is so refreshing. You are so refreshing. And I too, like Dr. Patel, offer anything I can supply and provide, because we're having to dismantle these canons across every single discipline. And nursing has been one of the last kicking and screaming to come to this place. And so to see the work that you're doing is just so rewarding. So God bless you. And I know I could say that because you're a Catholic or something. So bless you.
Thank you, thank you. You know what, when I think about accountability, when I was putting on my dissertation, I was terrified. I was terrified of how I was going to be received. And I put that fear front and center at certain times, too much. And then someone who I look up to, a scholar, thinker, she came up to me after my first presentation and said, I think you will help us change the canon of nursing education. And it wasn't until then that I realized the weight of responsibility and potential in the work I was doing. So I appreciate you saying that and believing in the work. And I carry all of you with me, and we are carrying each other in this work. It's so needed. And so thank you so much.
Okay, we'll miss you. We'll hope to see you soon. Hope to
Take
see
care,
you again.
I think you will be receiving many emails.
So,
Email me. And thank you again, Vivian, for your question. Take care, everyone.
thank you, Megan. Thank you,
Thank you.
Dr. Tillman-Meekins.